last part, how we organize the safety net for the healthcare. It's called CMU, Couverture Médicale Universelle. It has a nice little picture. And the whole medical policy in France, you can trace it back to two sets of principles which sort of come together towards an idea of universal access. Medical ethics, doctors have in France, at least in Europe widely, always cared for anybody even if they couldn't pay. It's part of their ethics. They have to swear when they become a doctor, I promise to do this and that, and part of this promise is I will care for everybody independent of what he can pay me. This is of course just ethics, it's just words, but there's some mentality of this. And there's a public service ideology which thinks that everybody should be treated equal. That's the French Revolution, so that means you have to have exactly the same thing. You cannot have special advantages because you are somebody else. For instance, everybody's treated the same way in the law court, in the school, and in the hospital. So these are things which are very strong, not generally for social security also, but particularly strong in the healthcare sector. So why do we need a safety net, given that we have a compulsory affiliation of all working people to the health insurance, all students, all pensioners, and all their family members without extra charge. So that's nearly everybody. Unemployed people are insured automatically as long as they are compensated, and a little time afterwards, a few months up to a year, something like this. It's a unified system with the same benefits for everybody, just 3 branches for employed people, for independent people, and agriculture. So we don't have the system you have in Japan, where when people are not working, then they are in a local insurance, and the ones who work are in some other insurance. That we don't have in France. Everybody is in the same. At the origin, at the first years, it was very much only for people who worked or got pension from work or something like this. And other people had problems. But it was generalized, the access to the health insurance, during the 60s and 70s already. And even there exists a personal affiliation for people who are not eligible with all these regimes. So why do we need a safety net? Well, because there are limits to universal cover. The social health insurance model was built on full employment. Everybody would be either employed or pensioner or independent or something. It was not thought for people who have very interrupted careers, working a week here and a week there, and meanwhile not being covered. And it was not thought for people who stay out of work for a long period as unemployed, or elderly workers who can't get a job anymore because of age and not yet old enough to retire. So there is a hole. As unemployment grow for young people and for the elderly worker and for the unskilled worker, there was a problem of health insurance access. And it would, in order to close this gap, it would need access based simply on the fact that you are living somewhere, on residency, which is normally the basis for public assistance, not for social security access. But that was recognized as a real need. France did have a law on medical assistance on residence basis, but it dated back to 1893. It's not 1900, 1800. And it was outdated, it was discretionary. The mayor or the local administration could decide they would help you or would not help you. There were no national rules. And it produced unequal conditions and benefits all over the country. And that is something the French don't really like, because it's against the principle of equal treatment. So something had to be done. And there was also the problem, doctors avoided these assisted patients because the tariffs were set without discussion by some administrator, local administration, and they were generally very low. So doctors rather said, well, I don't even bill it. I keep you, I treat you as it is, but for the second time you go somewhere else, something like this. So, and there were public hospitals people could go to without paying. So there was care, but it was all very badly organized and was not very dignified. And the personal insurance for those people was just too expensive because the tariff was the same whether you worked or not. And if you didn't work, your employer wouldn't co-pay, and you had to pay the two parts. So there were institutional limits, but there were also financial gaps in access to care, not to the health insurance, but to the care, because the reimbursement by health insurance is in average about 75% in average, because there are very different cases. If you are really very ill and you go to the hospital, you get all paid for. There's a list of illnesses, and when you have all this cancer or whatever, unless you go to a very private clinic with very private doctors. For all other treatment, it's much less. If you go just to the doctor because you are sniffing, you will have to pay sort of a third from your pocket. Prepayments, you have to do prepayments, so you have first to pay, not for the hospitals, but for many, many institutions. And afterwards you get reimbursement. So if you don't have the money, you can't advance it. And it's just a law passing now, it's just implemented right now, where this third-party payment will be enlarged, because people have problems with this. And you had only symbolic reimbursement, nearly nothing, for very important things like spectacles, hearing aids, dental replacement, and even dental care, and diverse equipments you could need. So there is part of the care which is not reimbursed, and private doctors also overcharge. So all this brings you to the idea that you need a complementary private health insurance, and nearly all French people have it. So, but the poor, they can't afford it because they have to pay for it. It's a private thing. You pay first from your salary for these others, but if you don't, if you have no salary and all this, it's difficult to buy a private health insurance, and you will only pay part, not the basic. So there was a problem of access. And especially this problem of private complementary health insurance, which most people have. These are private bodies. They can be commercial bodies or not-for-profit. 60% even today are about mutualist societies, which are non-for-profit sort of ONGs. Premiums you pay, they either take part of your salary, which makes it like the tax, or they take according to your age and your family members. That means it's risk connected, how much you risk to cost them, or it's mixed. I talked to the French specialists, the MGON takes a mixture. They take it from your salary, but then they take a little bit more or less if you're family members and if you are aged or not. So they take risk in, but to a lower percentage. So all sorts of things are possible. You may have individual contracts or collective. If you are just an individual who wants to subscribe, you take their conditions and you decide. You can look on the market. But if you have a collective contract because your employer or your administration makes a collective deal with some of these societies, then you probably have a better deal. You get more for your money. So if you are outside the working world, you won't access these. You can only access with a private individual contract, and it will cost you much more. But because collective contracts are more interesting, and the government is now trying to privatize a little bit more of the health expenditure, so it pushes more towards the need of complementary health insurance becomes bigger for everybody. So they decided in a recent law, I think it was 2 years ago, it's going to be implemented right now, all employers, except the public employer, are now obliged to offer complementary health insurance to their employees. It doesn't mean offer money, but they have to negotiate a contract and offer you, if you would like to subscribe for these conditions, which are much better than what you could get alone on the market. Here is a contract you can subscribe. This they have to do. That's recent. That's a new thing. And I think they didn't do it for the public service because they all have their public service mutuals. And they deal it out directly with them. So there was an opportunity window at one moment to sort out the problem of the safety net for healthcare, because we had policy contradictions and we had new actors. Now, the details. There was a policy being made on, since over 20 years, on fighting poverty and social exclusion, which notably introduced the minimum income scheme in '88. And this provided, that was a step forward, a first important step towards the general health insurance for everybody. It provided free and automatic affiliation to the public health insurance. Once you got the minimum income, you were health insured as anybody else without paying. That was sort of automatic, so I just exchanged information and it was done. And then we had, well, in the same type of policy, 10 years later, the socialists decided this, a policy which was quite important to secure access to all fundamental rights. So they checked all the rights and said, what is the reality? Do people access these rights? Legal rights, for instance. If you have a fight with your neighbor and you are poor, you can't afford a lawyer, what's going to happen? So they said, well, you have to have access to free lawyer service because you're poor. And they checked it all, and they found that there was a lot of holes for healthcare. So there was a policy stream towards giving all the poor people their fundamental rights, and particularly healthcare. And there was a precedent. All those who got minimum income allowance, they were automatically free insured. We just needed to add the others. The other policies stream was cost control for healthcare. Everything was cut a little bit more, and people were more controlled. If you didn't have the right paper, you couldn't go. So flat rates were introduced. You have to pay every time now €1 when you see a doctor, and reimbursements were a little bit lowered. Many things which made the need for complementary health insurance even bigger, because more and more people, this means complementary health insurance, and more people were at risk of renouncing to care even if they need it, because there was a money problem. And also in '96, the prime minister of that time wanted to organize all these problems, including the money problem, and he put up a huge reform for the whole social security system, including health. For health, he was a conservative party, but he brought forward a very revolutionary program of a unified health insurance. All these different branches together, the private one and the public one, everything together, and everybody should access. But the whole left was shouting against it because it was against the old principles and so on, and it was because cost containment. So it was total failure for the health subject. Nothing came out of it, but it was a period to learn. So there was policy failure, two policy streams that went into the same direction. Because we had to do cost containment, we had to better insure the poor people, and because there was a policy giving more to very poor people, ensuring their rights, that we had to do something. And there were strong advocacy groups, more issue advocacy groups, which were basically the doctors from humanitarian organizations, because they worked with all these poor people, illegal migrants, Roma, people completely excluded, mentally ill, and so on, people who have no home.